So we first drained the choroidal hemorrhage. Then we did a pars plano lensectomy, and here you see the retina is incarcerated in the scleral wound. We cut it free, and we peeled a lot of the membranes, which we're not showing here. It took considerable time and effort. We eventually opened up the retina with perfluorocarbon liquid, and there were membranes both on the outer surface and the inner surface, and then we lasered in. Here's the intraoperative view with the 360-degree giant tear and the retina incarcerated in the wound, the closed funnel. Here you see at the end of the case. Here you see post-op week 1, the patient has count fingers at 4 feet, which is better than one would expect. I've probably done 5 no light perception cases in my life, and none of them have turned out extremely well. They've all ended up maybe hand motion or count fingers if we're lucky, but this gentleman at 4 months post-operatively ended up 20/60 pinhole to 20/50. He then developed epiretinal membrane, and his visual acuity went to 20/70, 20/80, and 2100. We peeled the membrane and he came back to 20/60 at 7 months post-operatively. So what's unique about this case as to why this one case may have done better than the other cases is there was no blood in the vitreous cavity. So we all know that the blood is toxic, and it's toxic to the photoreceptors, and when the retina is detached and there's blood under the retina, the blood can damage it, and in this case there was no blood in the vitreous cavity under the retina, since the retina was totally detached. The blood was all in the suprachoroidal space, which is a separate compartment, and that probably accounts for why the visual acuity in this case turned out well, despite the fact that he was no light perception of presentation. The second case is a 23-year-old gentleman who had a nail gun injury. He had an open globe, and this is a laceration, unlike the last case, which was a rupture. And his presenting visual acuity was hand motion, and the trauma service did the primary repair. And he had a limbal to limbal superior corneal laceration, in this case, zone 1. So zone 1 is just the cornea and the limbus. Zone 2 is between the limbus and the muscle insertions. And zone 3, like the last case, was posterior to the muscle insertions. So initially we thought this was just zone 1, and then he was referred to the retina service. So here you see the corneal sutures. He also had a traumatic cataract, and this is what he looked like when we first saw him. So you can see the vitreous has pigment and hemorrhage, and the vitreous is streaming towards the wound. And an ultrasound looks like it might be showing a relatively low-lying retinal detachment of the macula. But this ultrasound view is a little more concerning. This looks like it might be vitreous and/or retinal incarceration in an exit site, meaning the nail went through the cornea and out the back. So this would then be a zone 3 injury. If it's a zone 1 and a zone 3, it's just designated with the highest zone, therefore this would be a zone 3 if that was the case. We'll find out in the OR. So this is the exit site. You can see where the nail punctured the retina, and we're cleaning up a retina. You can also see there's a large submacular hemorrhage. There's a retinal detachment involving the macula that extends to the exit site, so there's a little hole around the exit site, but there's a lot of blood under the macula. So what we decided to do is a retinectomy around the exit site, number 1, to relieve the traction, although there wasn't too much traction, but number 2, to get out the blood. So we put perfluorocarbon in, and you can see some of the blood here being displaced from the central macula, pushed towards the hole, and you have to shake the eye a little bit, as you'll see, trying to get the blood to move toward this hole, and you can see it coming out now. We're aspirating it through the hole, and we took the perfluorocarbon out and put it back in, and we did this 3 times to squeeze all of the blood out towards the hole, and here you can see you don't really see much blood anymore, and we're drying off the hole. And then we laser around the hole. And we can see just post-op week 1, the retina is attached. You see a little bit of blood back there, but not much. You see the exit site with the retinectomy around it, which looks nice with laser. Visual acuity is 2200, but keep in mind he's aphakic, he has oil, and he has not been refracted. And you can see with the autofluorescence photo, it shows the blood better, so this is the only remaining blood, which is pretty good considering the blood was covering the entire area underneath the macula. And here we see the retina attached on OCT with the oil reflex. So these represent 2 unusual trauma cases. Both turned out to be retinal incarceration, one from a rupture, the other from a laceration, and in both cases the retina was freed up from the incarceration site to relieve the traction, and both patients did well.
For discussion, if there are questions, please raise your hand. Well, Frank, regarding your presentation on surgery in children, I saw you implanting the lens. From what age do you consider implanting the lens?
For me, I always put it at yes. If there is any malformation, perhaps then it's the only manner to have a little visual acuity after.
And do you take into account that the eye will still grow, so when you use like a 20 diopter lens, or will you adjust to the actual length of this eye?
I try to calculate the IOL when the eye was adult size. And we have to put some lenses or some glasses before, and then reduce it progressively.
You've shown nicely that in very young children, neonates, there's virtually no pars plana. It's very difficult to find it, and you get easily choroidal hemorrhage if you touch the choroid or retinal incarceration. So what I usually do in such cases is I use a limbal approach, so I make 2 limbal incisions. I cut away the lens, and I work through the limbus into the posterior fold. Is that an approach that you also follow?
Yes, I not a very good experience in neonates. We work in a private structure, and for the anesthesia, it's difficult to have duration under 5 kilo. That's the reason why.
Dean, could you comment on the time that you take into account between the closure of the trauma and vitrectomy? I mean, what's in your view the ideal timing, and which factors do you take into account?
So we usually do the vitrectomy, the secondary procedure, about 7 to 14 days after the primary repair, after the injury. And in young patients, we tend to go closer to 14 days, but generally a week to 2 weeks. The reasons are, if you go too early, sometimes there's too much hemorrhage, and if you go too late, and also if you go too early, you don't have a posterior vitreous attachment. Sometimes it takes a while for the posterior vitreous attachment to develop, especially in a young patient. If you go too late, obviously if the retinal detachment is there, you're increasing the duration of the detachment, which is not good. That's our general guideline. I know there's a controversy regarding that, but that's what it is.
You showed us a drainage of the choroidal hemorrhage. When I do this, I install an anterior chamber infusion, and I use that as an internal pressure to push the blood out. I think I saw it do it differently.
Yeah, we had an needle in the a butterfly needle in the anterior chamber with a syringe attached, and somebody was pressing the syringe while we were training.
Now, Zach, you gave a presentation on 27 gauge. Did you try using silicone oil in 27 gauge?
And the opportunity to use silicone yet, but I would imagine it would have to be an active infusion to be able to do that.
Well, I gave it a few tries. The problem is that if you inject silicone oil, usually we use a VMI cannula, which we use through the throat bar, through the instrument cannula, I should say, which narrows it even further down. So a system that would fit over our instrument cannula would work better. We had a few prototypes developed with Dorc. The problem is that you use such a high pressure to inject oil, 5-6 bar, that it's very difficult to keep it attached to this instrument cannula. Now, injecting silicone oil, even with the VMI cannula, is feasible. It just takes more time, 5 minutes, 10 minutes. But extracting it goes to 20 to 30 minutes. So, although I do most of my cases now 27 gauge, if I have to use silicone oil, I stick to 23. Is that also your experience? In your title slide, there was a case with a bilateral trauma. What happened there?
That was a very sad case of a woman who was mentally ill, who took 2 golf pencils and did this to herself. She was no light perception, both eyes, because they severed the optic nerve. I've had bad rounds of golf, but that's extreme.
And maybe the last question. Oh no, I have 2 more. I have a suggestion or a question. If you do a capsulotomy or an iridectomy, I usually do it, well, I always do it dual linear. So I put a cut rate of the EVA to 1 cut per minute, and the aspiration to 0 to 350. So when doing the iridectomy, I rotate the vitrectomy with the opening towards me. I go under the iris from behind. Then I aspirate, I flatten my foot pad, I get 350 millimeters of mercury, and then I move my foot down to the right and I get 1 cut. Usually that's just enough to create a nice and decent iridectomy. I found if you have the cutter, I cut 800 times per minute, so it makes at least 2 or 3 cuts before you can stop and you make it too large. Is that also how do you do it? Yeah. So 1 cut per minute is.
Using the 27-inch cutlet capsulectomies, where again, this was not very effective. Again, it's something that you just put a single incision parcel version, much the same setting that you've done, high vacuum, low contract.
When you do trauma repair, you usually use silicone with these heavy traumas. You take it out after a couple months.
So we leave it at a minimum of 3 months, depending on the situation. Sometimes we leave it 6 months, 9 months, but most are about 4 or 5.
Yeah. And then you take it out, and in my experience, often you have a reattachment, and then you put it back in, and you take it back out, and you put it back in. When do you stop?
Well, we hope that doesn't happen, but sometimes that happens. I think if a patient redetaches and you have to put the oil in, I may leave it in for a pretty long time, the second time, and not remove it after 3 months. Wait till it probably starts emulsifying, which might be about a year, then I may kick it out.
That's what I wrote down. Are there any questions from the audience?
About the use of ochriplasmina in children vitrectomy in children.
So the question is, how about using ochriplasmine in children? Now, the idea of using ochriplasmine in the eye actually comes from the work done by Mike Treacy and George Williams already a long time ago, when they injected autologous plasmine in ROP children to ease the surgery. And actually the very first trial ever done with ochriplasmine, the BV1 trial, was exactly using it before surgery to make the PVD creation easier. Now, during this trial, we noticed that when we injected patients with VMT and macro before the surgery,